The programming during this crazy COVID time, I've been very impressed with how on point it has been. I was pleasantly surprised with how topical some of the speakers were in the law enforcement department. Just last month, there was the president of the Milwaukee Police Association. So to have those people in very high positions be able to be interviewed and answer questions that are on the top of everyone's mind. Okay, what do you think about the calls to defund the police and all the unrest and racial injustice that's going on in the community? I think it's really impressive that we've been able to have those speakers, within weeks of some really significant national news events going on. It won't be like this forever. We'll need to get back to normal life eventually, even though I'm sure it'll look slightly different. And those connections are still going to be important no matter what type of work people are in, and particularly the community building aspect and community rebuilding after all the kind of destruction that COVID is going to have throughout the community. It'll be important that we keep a network of people who are willing to talk and willing to invest their time and money in the community.
My dad was on a service trip, and somebody had like a heart attack, in a foreign country. What do you do? It's scary here, it'd be scary anywhere. But they made a call to the local Rotary Club, and it just literally the wheels were in motion immediately. And there's so many programs that Rotary has. So shelter box, right? Literally there could be a tornado in Kansas, or there could be a hurricane in Haiti, and this team is prepared and mobilized and can get out and get people these boxes that can support families for 20 days. What I really like about Rotary also is that creativity counts, right? Be it logistics, be it wellness services. It goes so far. So case in point, all the work our club does in Guatemala, and they went there for one reason, but now it's, it's clean water, it's bridges, it changes, and it ebbs and flows as to the needs of the people that we've connected with.
Welcome to the Rotary Club of Milwaukee. I am Club President Darren Miller, President and owner of JM Construction. As we gather virtually today, we will begin the program with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And now, Chris Jacobs, past Rotary Club of Milwaukee president and shareholder with Davis Kilthau attorneys, will give our invocation today.
Thank you, President Darren. Our invocation today strikes at the theme of Thanksgiving, since it is, of course, Thanksgiving week. And I came across a prayer from an unlikely source. In this case, it's a prayer of thanksgiving from Ralph Waldo Emerson. So if you'll bear with me, I'll share it with you. For flowers that bloom about our feet, for tender grass so fresh and sweet, for song of bird and hum of bee, God in heaven, we thank thee. For blue of stream, for blue of sky, for pleasant shade of branches high, for beauty of the blowing trees, God in heaven, we thank thee. For mother love and father care, brothers strong and sisters fair, God in heaven, we thank thee. Amen.
Thanks, Chris. And thank you to John Ferguson and Margaret Cry for your contributions to our Rotary Now More Than Ever video series that played during the program's start. The pandemic surely has been a challenge for many of us, and the Rotary Club Milwaukee has had to make quite a few accommodations. Some have been difficult, but we've been gratified to hear that many of our members believe in Rotary now more than ever. We'd also like to say a thank you to Rotarians that joined us to sort food at Feeding America last Friday. This was a great way to connect with fellow Rotarians and make a difference in the community. As you've read, food bank services are in high demand right now. You can see a few of the images from last Friday here. And also, due to technical issues last week, Michelle was unable to share pictures of the new mural at Feeding America. She is now sharing those photos with us. Feeding America Eastern Wisconsin worked in collaboration with artists working in education to select local muralist Aisha Valentine to tell their story of solving hunger and uniting the local community. You'll note a call out to Rotary, and many of you may have noticed the arch that frames the entrance to the Rotary, Milwaukee Rotary Centennial Arboretum. It is also time to sign up for our annual bell ringing with the Salvation Army. On Saturday, December 5th, from 11 a.m. to 7 p.m., you and your family can sign up to ring bells at 2 Metro Market locations, 1123 Van Buren and 4075 North Oakland Avenue. See the link in this morning's email to sign up for one of those hour-long shifts. The Rotary Person of the Year Committee is now accepting nominations for the 2021 Rotary Person of the Year. Nominations for the award should be individuals who, through their profession, have made the community a better place to live and work, and have shown outstanding leadership in the advancement of ideas, products, and services. If you would like to submit a page-long nomination, please send it to info@milwaukeerotary.com. The deadline to submit your application is January 14th, 2021. The Rotary Club will celebrate the award recipient at a May or June Rotary meeting. An update with our RCM Scholarship Endowment fundraising efforts. In just 1 week, we have raised over $5,000 for the endowment from our members. Thank you to all who have donated so far. Finally, if you are joining us today on Zoom or YouTube, please use the chat to text in your questions. And now, Alex Chow, Realtor with Keller Williams North Shore, will introduce our speaker for today.
Good afternoon, everyone. I'm Alex Chu, and it's my honor today to introduce Dr. Tony Thrasher to talk to you about a very appropriate topic for 2020, mental health. Dr. Thrasher is one of those unsung heroes in the community that you never hear about precisely because he and his staff do their incredibly difficult job so well. Dr. Thrasher is a board-certified psychiatrist and the medical director for the Crisis Services branch of the Milwaukee County Behavioral Health Division, which includes oversight of the Psychiatric Emergency Room Observation Unit and associated mobile crisis teams. He received his psychiatric training from Wash U in St. Louis and Barnes Jewish Hospital. He is a distinguished fellow of the American Psychiatric Association, and he currently serves as the Milwaukee chapter president for the Wisconsin Psychiatric Association. Additionally, he enjoys teaching as a clinical associate professor with the Medical College of Wisconsin and serving as the president-elect for the National American Association for Emergency Psychiatry. His professional interests include medical leadership, physician development, chronic psychotic illnesses, medical education, and underserved medicine. He's proud to be a past National Health Service Corps Scholar, and he currently serves as the chair of a statewide task force focusing on the collaborations between psychiatrists and emergency physicians. Additionally, he's the editor for the pending Oxford Press Primer on Emergency Psychiatry, and he is a fellow of the American College of Psychiatrists. So I looked that up, and it means that he's considered to be one of the top 750 psychiatrists out of 46,000 in the country. So without further ado, I present to you Tony Thrasher.
Thank you very much, Alex. That's a very kind introduction. And I did not know that last statistic, but I appreciate you looking it up. I will try to use it in other things from here on out. So once again, just thank you to the group for having me. This is a very esteemed group of people. and I feel very fortunate to be able to spend the next 30 minutes talking with you on what I find to be not only a very important topic, but also a very germane topic. As mentioned, my name is Tony Thrasher. I am a psychiatrist with Milwaukee County, and my primary role is oversight of crisis services, which is predominantly the component of healthcare that is not quite the inpatient level of care, but yet not an outpatient clinic. It's kind of everything in between, which makes it a lot of fun to work with, but also very challenging and also very specific to the type of things we're going to talk about today, which is mental health, suicide, and how we cope during what is a historic pandemic for our generation. So I always leave my contact information. Email is usually the best way to get a hold of me. The reason I like to do this is if you're like me, sometimes I think of my best questions long after the presentation is over. So by all means, if something comes to your mind on this down the road, feel free to reach out to me. I also acknowledge some of the things we may talk about today may be very emotional. They can be very personal. You may, in some of these scenarios, see yourself or a friend or a loved one or a family member or somebody that you have worked with before in the past, and it doesn't feel very comfortable to ask questions in front of a large group. By all means, please do reach out to me via email afterwards. Consider this an introduction to this topic and not necessarily the only 30 minutes we're going to talk about it. Disclosures were already mentioned earlier. Thank you very much. Nothing financial pertaining to this particular talk. So here's what I would like to do for the next 30 to 40 minutes. And by all means, if you have a question, speak up at any time. It does not bother me to answer questions during the talk. If not, I do believe we'll make sure to have some time at the end as well. But these are the three large topics I would like to cover. Number one, we have to look at what a pandemic is, since this is the first one that we have lived through. We have had other pandemics in history, and they have led to similar changes in society, some of them beneficial, some of them not so much. So we'll look at the best ways that we can kind of visualize this through a scope of how not are we only going to survive this, but also find some positives to come out on the other end. Number two, we'll get into some specifics. How has COVID-19 affected either current problems that are pre-existing, which they are affecting, and or kind of creating new problems, things that we had not thought of prior to said pandemic, that we now have to expand our service array to make sure that we capture everybody that's in need. And then lastly, at the end, I'm going to go over some adaptive ways to handle this. Some of this will be at the individual level with information that you yourself can think about that you could use in your daily life. I would also like to include a lot of resources at the end. So by all means, this particular slide set that I've shared with the Rotary is happy to be used by anybody. That way you can refer to it for any resources down the road. Now, many of you, whether you have a background in mental health or not, you may have heard of this particular topic, which is Kubler-Ross stages of grief. It's 5 particular phases that many people go through when grieving. Not always these 5, not always in this particular order, but very often a majority of these. When I approach the pandemic, I approach this from a perspective of grief. We are grieving for a life once lived, and that can mean from things that we were used to, such as going out to a restaurant after work and talking with friends. It could mean missing out on hosting a 40 to 50 person Thanksgiving that we really look forward to every year. I say that as a personal amount. We're going down from a 40 to 50 to 4. These are things for a life once lived that we are grieving. And so whether you work in industry, business, healthcare, or education, I'm noticing that most people are going through grief. Hence, I'd like to approach it from these 5 topics. From a denial standpoint, I would argue many people still understand that that phase has since passed. This is a problem. We are in the midst of a pandemic. It is real, and it is affecting us in many different ways. A lot of people understandably have anger on this, which is why we're going to look at data and see how this has affected people in the past and how we can use it, hopefully, to our positive end. Bargaining. You may find people that want to talk about this is going to go away, right? Just a couple months here, just a couple months there. I think we now know that that bargaining component has since passed. I would say most individuals I work with are now somewhere in those 4th and 5th components. A depression, kind of knowing that the pandemic is here and how it's affecting us and heading towards an acceptance of how we can approach this. I sincerely hope that our talk today, if any of you are in these particular stages, can get us closer to acceptance. That doesn't mean the other stages vanish, but it does mean it gives us a more healthy, adaptive way of coping with it. So let's get started with some info. First off, I told you I wanted to mention history. Unless any of us out there are 102 years old, nobody has lived through a pandemic yet until now. So this is something we have to keep an eye on. And we've had pandemics in the history of the world before. And because of the current one, we're seeing more and more writings about them. I just list some of them here. The one that most people are currently comparing this to is the most recent, which was the Spanish flu of 1918. But there have been several other pandemics throughout history that have affected civilizations, including things such as the Black Death. And I would include in that the colonization of North America by Europeans, which basically decimated the indigenous people at that time by exposure to European illnesses that they had not had any type of resistance or immunity towards. And you'll also notice that a lot of people have talked about how pandemics leave us forever altered. That was noticed back in 1918. In the beginning, they weren't keeping a lot of research on that. But if you look into the 30s, 40s, and 50s of medical research, when they did retroactive examination of the last pandemic, they found some poor medical outcomes, which doesn't surprise anybody. And probably what is most concerning, and what we are seeing today to a point, a U-shaped mortality, meaning that it is an illness that are often killing the very young and the very old, which is, from a cultural standpoint, very concerning because it is affecting both your future and your history. And that's something we have to keep an eye on when looking at this pandemic, not just in the morbidity or how it sickens us to a point, but in its mortality. I'm just going to give you a couple more examples because I like looking at these things from a historical perspective. Many times in the past, pandemics have affected the course of fate, so to speak. You can go all the way back to the Peloponnesian War, when Athens was a shoo-in until typhoid took over the most of their armed forces. One could look at that bubonic plague that I'd mentioned, where almost 60% of the world's population perished. That was the first beginning of actual industrialized nature of hospitals, public health systems. It also helped end feudalism. Once you lost the majority of the people that were supporting your estates, the idea of having feudal lords quickly diminished. And the yellow fever is very well noted, at least in the French literature, that one of the main reasons the Louisiana Purchase was so cheap is because the majority of their forces had already lost Haiti and could not hold on to further military operations in, at the time, North America. And even internally, we've had several disasters that we have bounced back from and done well on. The New York fire was a great example of the first time when fire departments said, wow, it would be great if we had water supply that was available throughout the entire city, hence aqueducts. Cholera in the UK started issues with sanitation, health reform, and very close to us, the Chicago fire. When those buildings went down, 20,000, it was the first time that people started saying, maybe we should look at some more expensive material other than wood to build our most important buildings. The skyscrapers were born, and the idea of connecting these things through different infrastructures and programs really grew out of these extensive natural disasters. And I don't share all this to be artificially optimistic. These are very tough times, but I sincerely hope that somewhere down the road, when perhaps our great-grandchildren are examining history, they will see that the way we have handled this, we have also made the most out of a very difficult situation. So, history being aside, let's look at some of the scientific studies that really speak to mental health and suicide in our area since the pandemic. So first off, this is out of the American Journal of Public Health, just popped a couple months ago, and I just liked this quote, so I put it in verbatim. The social isolation, check, financial hardship, check, and fear associated with this pandemic could present a perfect storm for public mental health in the US. I think the word could here is very kind. It does present a perfect storm for public mental health. When Wisconsin was first having its cases of COVID in March, I was ironically down at the CDC training in mass disaster and mass mental health and mass response at one of the sites in Alabama, where they run you through drills in old military facilities. And what we noted was I was there with public health officials from all over Wisconsin. And since the public health people were there in Alabama with us, they are often the only employee of their division. And so they were not here in Wisconsin. It was a real eye-opener to see how much public health as a whole has been somewhat underfunded over time. And what this data basically showed is that these mental health symptoms were tied to how much diagnosis of COVID one had. So if you are in state B and you have twice as much COVID cases as state A, you are likely seeing a parallel in twice as many mental health issues. This came out of Helio, which is directly from the CDC, and not surprising to anybody, the two subcategories of mental illness that have shown the greatest rise since the pandemic have been anxiety disorders and depressive disorders. There are many other disorders which we treat, which are being complicated by the pandemic, but we aren't necessarily seeing an increase in, say, schizophrenia disorders or obsessive compulsive disorders or things of that nature. But they have noticed that if you had a pre-existing diagnosis, we are seeing increased amount of obtaining a positive coronavirus test, and if hospitalized, worsened outcomes. We don't have rationale for that yet, but it's clear that those with pre-existing mental health conditions, particularly chronic mental health conditions, are having a much harder time of it if and when infected. And what are some of those adverse outcomes? I don't think anything on this slide will necessarily surprise you guys, but it's worth talking about. There's concerns over the psychosocial stressors. What's going on in my house? What's going on with my job? How will the illness affect my ability to either provide for my family or support people at home? What type of phobias are people having more? I would argue we could talk an hour on that, on how the pandemic has taken somewhat of a political and a dichotomous trend with a lot of anxiety and type of fear-driven dialogue. A lot of disturbances of sleep. You are seeing more and more people with increased social media. Once again, a topic we could spend 4 hours on. The pros and cons of social media are very much out there. What should be noted is during the pandemic, there is more usage of social media. So I'm guessing the pros are accentuated, as are the cons. You're also seeing extensive increase in alcohol sales and use. And while that can often be kind of used as a humorous component, I know when in Wisconsin, there's sometimes a pride in this, which we'll talk about in about 10 to 15 slides, but it is concerning. It's concerning from a public health standpoint with the medical issues that may exist, as it does tie in to my last bullet point on this slide, which is we are seeing extensive increase of domestic abuse and child abuse calls to the hotlines. Now, this could be because more people are calling. In other words, these cases always existed and now just people are notifying more. Or as many of us hypothesize, some of the issues with kids being home more and being around family members more may be leading to the realm. This came out of the Journal of the American Medical Association this summer, and it's pertinent to something that Alex mentioned at the very beginning, which is your healthcare professionals. I'm obviously biased in this. I am a healthcare professional. I worked a 14-hour shift last night, and I can tell you all of these feelings are still very real. When they spoke to any healthcare employees that worked either in hospitals or frontline ERs, they basically said the same things I think anybody would want to know. Hear me, protect me, prepare me, support me, and care for me. And I think what you're seeing right now that is most concerning and what we're calling the second wave of COVID is during the first wave, healthcare professionals were affected, but not in as high of a percentage. And we saw this also with the data from China and other countries that have, I would argue, more successfully navigated this pandemic, is that the healthcare providers' burden and issues with illness and burnout definitely exponentially increased as time went on. The first wave was minimal, and each subsequent wave had more and more contribution and negative outcome on this very small group of people that we are depending upon to keep people alive and keep people safe. And one thing else we have to talk about, particularly speaking as a Milwaukeean, is that there are some disparities here that we don't fully understand yet. Hopefully we will, as more coronavirus research is had. But I pulled this out of the New Yorker this past spring. There's a great quote that I don't think anybody's ever attributed that you hear a lot in my line of work, which is when white Americans get a cold, Black Americans get pneumonia. And that speaks to other illnesses other than coronavirus. There are worsened health disparities for Black Americans as opposed to non-Black Americans. And so we are seeing that in our city. We are seeing that in our country with a higher percentage of hospitalizations and a higher amount of both morbidity, meaning how sick they get, and mortality, meaning the rate at which people die. Now that's led to some really interesting questions when it comes to medical ethics. And I think as the vaccine starts to roll itself out, this is only going to increase. You'll probably have more articles on this than you can shake a stick at, which is who is going to get the care? Who are considered essential workers? Whose jobs are maintained while whose jobs are laid off? When funding and or vaccines and or treatments come out, who gets them first? How much is rationed out to each individual group? This is all some issues that are not morals. Morals tend to be more black and white, but are more ethical issues that are very nebulous and ever shifting depending upon the lens with which someone views them. So in these particular case, I would also keep an eye on these things, particularly as the vaccinations start to roll out. Now, when I think people think of the mental health issues with COVID, I tend to think of the slides that we just had. I think these upcoming slides are much more pertinent to the average person because the thing that most people kind of connect mental health issues to, particularly uncontrolled or exacerbations of mental health, is suicide. And there is a perfect storm here. We are seeing a significant increase in suicide. And to be fair, suicide rates were on the rise prior to COVID-19, which we'll talk about in a bit. This comes out of the Journal of the American Medical Association specific to psychiatrists. Notice that rates have been up over the past 2 decades, but now we are seeing a steeper rise since COVID-19. And the main comments that were brought up, I think some of these are rather obvious and some of these are a deeper dive. The issues with being distanced. For a lot of our patients, their treatment, their well-being is tied not just to medicines, but social contact, social interactions, what I like to call the prescription for kindness. Simply being with people, and sometimes even if you're not able to solve their problems, being there as a witness to their suffering is a very important component of being a human being. And that's been limited, even though the technological advances have been wonderful, and hopefully that'll be something that we can grow even after the pandemic. This is an issue that's affecting people. You're also seeing a lot of issues with parity and funding. And I'm guessing for many of your questions, which I think we'll have at the end, a lot of times my answer is it's not funded. If I'm going into a hospital and I need my gallbladder removed, no matter what insurance I have, that's probably going to be covered, even though in most cases having your gallbladder removed is an elective procedure, can happen anytime. However, if you're presenting to a hospital for mental health concerns, the funding is not the same. Systems do not treat this the same. Just before I logged on with you, I have 2 emails I'll have to tend to after this of hospitals that won't treat a certain individual and want somebody else to treat them. That still exists in the world of mental health, and I do believe it's a direct, at least correlation, if not causation, to some of the increase in suicide rates. And as mentioned earlier, this mental health and suicide risk pertains not just to the general population, but also to healthcare workers in general. You're seeing a significant increase of suicide in the entire workforce. To be fair, physicians have had one of the highest rate of suicide in the past quarter of a century. That's been going up for 25 years. More physicians kill themselves, enough physicians kill themselves every year to fill 2 incoming medical school classes. So given that we're living in a world of physician shortages, that's concerning all in of itself. What this article really brought to light is it's not just physicians. It's nurses, it's respiratory therapists, it's certified nursing assistants, it's radiology techs. You're seeing a high amount of suicide increase. They're feeling less time to take off, less time to unburden themselves. And one thing that comes up a lot in mental health and in medical care is forced choices, which really get to the root of who a person is, where they're forced or feeling that they're being forced to do certain actions that really goes against their moral code. And that tends to lead to something called burnout, which has been such a hot topic for the past 2 to 3 years. I hesitated to include it here, but I think it's a worthwhile for half a slide just to remind people that burnout is persistent, not just in healthcare, it's persistent across the country. And it really kind of pertains of 3 big topics. One is feeling emotionally exhausted with your work, like you have nothing left to give, typically followed by a depersonalization, where you're still doing your job, but you're not saying hi to people. You're not getting together after work. The spark is starting to fade, if you will. And then lastly, the really concerning point is losing sense of meaning with one's work. And you can make parallels to suicide here as well. Human beings are amazingly resilient creatures. And as long as hope is present, they tend to do pretty well. However, once that hope is gone, or in this case, you believe that no matter how much you work, it's not really making a difference, then burnout and or thoughts of depression and suicide are typically not far behind. Another quote for you, please replace the word physicians with just employees. This was a physician article, but in reality, I think it really speaks to any type of employee that's currently kind of functioning during the pandemic. When it comes to stress and burnout, many of us are too busy to notice, too stoic to admit it, feel that they can internally handle it themselves, and or reluctant to seek outside help for appearing weak or having people question their competency and or confidentiality. And this is very true in mental health. If I was gone for a week and I came back and told everybody I had this rare rheumatoid infection, nobody would blink an eye. They would probably ask me a lot of questions and we would chuckle about it and I would move on with my day. If I came back after a week off and said I had been hospitalized for a hypomanic episode, I guarantee you my coworkers, my employers, and other people that depend on me would look at me differently. And that is still some of the stigma of mental health that exists. And I think it keeps a lot of people, particularly those in high functioning positions, from sometimes reaching out when help is there. So that being said, we've looked at some history. We've looked at kind of where the stats are. I want to give you about 5 minutes here on where things actually stand and how Milwaukee fits into this larger picture. So I'm very fortunate that in putting this together for you, the state put out 2 wonderful reports right on time. Otherwise, I would not have had such up-to-date data for you. This was just released, 2 huge, very well-validated objective reports. One of them was on a gap analysis. In other words, where are we missing the behavioral health and or mental health treatment? That came out from UW. And then also DHS, or the state health system, put out their yearly kind of state mental health and substance use needs. So where are the gaps and what do we need to fill, which I think is very germane to today's topic. First of all, you can look at this graph and note that suicide rates are up across the country. That's the light blue. And then Wisconsin is there in the red. So our rates are also going up. They're going up at about the same rate as everybody else's is, but at a slightly higher percentage. And then you see the 2 outliers there, the highest rate being in Montana, the lowest rate being in New York. You're also seeing, and we were talking about this before we went online today, the significant increase in both mood illnesses like depression and other serious mental illnesses in the range of 18 to 25. And I like to take a moment to really call this out because this is not just a concerning population for increased incidence or the increased diagnoses of illnesses. It's also the age group that we are now seeing the greatest rate in suicide. And that is concerning on many levels, particularly given a higher degree of impulsivity and a little bit of less lived experience up to this point when people are in that range of 18 to 25. Suicide in that particular range of 18 to 25 is now the 2nd leading cause of death. And that is, as a scientist, is mind-blowing. As somebody who grew up in the era of the 80s and the 90s where I was worried about drunk driving and motor vehicle accidents, to see that surpassed by suicide in my lifetime is concerning. Substance use trends are usually part and parcel to a lot of suicide issues and depression issues. What this basically showed us was across the country, ironically, the biggest increase has been seen for cocaine, which is making a bit of a comeback. Cannabis and opiate usages are pretty stable in Wisconsin. We're a little bit below the national average on that. The one part that should surprise nobody, but is concerning when speaking to depression and suicide, is alcohol. And Wisconsin continues to kind of lead the pack as far as a concern. Looking over here in the far right column, you're looking at least 51% of the country as a whole. It's almost 61% in Wisconsin. We outpace that pretty much year after year after year. Now, these next couple slides are going to take a little bit of explanation, so please stick with me, but I think they're very pertinent, particularly if you do most of your business and work in Milwaukee. I often remind a lot of people that Milwaukee has got it a lot better than the rest of the state. As I hear in all of my state meetings, there's a lot of interest in people in trying to recreate what Milwaukee does, which is ironic given some of the focus that is spent on some of Milwaukee things. But these are treatment gaps. This is objective data from the state that I think is very helpful. So what you're seeing here is how many adults are being treated for mental health needs. So if you look at the entire state, they're serving about 47% of who needs it. In Milwaukee, it's 57%. Now, mind you, I'm not going to be satisfied till that's 97 to 100%, but it's still good to see that we are heading in the right direction. Now, these other 2 columns are incredibly interesting because they speak to the public sector, which is kind of what I represent for you today, and the private sector. And we have great partnerships with the private sector, but I think this needs to kind of be noted, is in the public sector, the average treatment in the state is 25%, whereas Milwaukee is currently doing 31%. So we got a ways to go, but we're getting there. But if you look at the gap between the private sector, we see a much larger issue here. And this will be pertinent to you as I talk about the transition of the Milwaukee County services in the next 3 to 5 years. Because when you look at the private sector, about 28% of the state and only 12% of that in Milwaukee. Similar on the child side of things, we're seeing a very similar gap, only more disparate. So you're looking at the Milwaukee version, we're treating about 53% of what is needed compared to 41% for the state. But in the private sector, whereas the state as a whole is at 22%, Milwaukee is at 7% in the private sector. And so when you're thinking about what can we do, how can we improve things, something I always point to is this data. Because sometimes it's not as much that we need to do our current services better, we need more of our current services. Current services at any point would tap out. That's basic economics. The key is what else can you do to augment it to get some of this gap covered? If we're only getting 7% of the children in the private sector treated in Milwaukee, then we need more services. How about some other resources? We're doing fairly good on time, and I want to spend some time on what people can reach out to. This is probably the most common question I get. What can I do? I have a friend, I have a child who has a friend, somebody's at college. What do I do to seek help? Well, first of all, I like to point out some good national options. These are great national things. They run 24/7. The nice thing is we contract with them as well. So if somebody's on the National Suicide Prevention Hotline and the conversation is concerning, they will then dial us in because they know the person is calling from Milwaukee. So there's nice sharing between both the kind of federal resources and the local county resources. So you've got the National Suicide Prevention Lifeline. The number's right there. Has a website as well that's very user-friendly. I'd also point out we have our local crisis line, which has maintained the same number for some time on purpose. This is a 24/7 coverage line. This may help with resources, but it's also meant to handle actual crises. So individuals can be on the phone talking with our staff for hours at a time if need be. And I'd also keep everybody in the loop that the government did pass a new emergency 911 code for mental health, which I also think I'm very excited about. We worked on this at the national level, was instead of people calling 911, they can call 988. Now, I don't believe that's been operationalized yet, but it did pass Congress and it was heading into functionality prior to the election. The idea being here, how can a family member call 988 and perhaps get a mental health response prior to a law enforcement one? Other resources, I always remind people if really what you're looking for is just a resource. How do I get in to see somebody? How do I find access to food share or benefits? 211 is typically the best option, and that's a national number. However, if you need to get into issues with more crisis, where somebody's not doing well and needs immediate attention, I'd refer to those crisis lines that I mentioned prior. All their good groups here in town, NAMI Milwaukee, which I believe is currently starting to partner with NAMI Waukesha over time. They do a lot of good work, both with education and resources and also supporting families and those with lived experiences. Al-Anon is still one of my favorites that I refer individuals to, as long as people understand that Al-Anon has many chapters. So if you've tried one, it doesn't mean just because you didn't like that one, you wouldn't like Al-Anon. I always suggest trying different chapters because everyone has a different feel. And the idea there is really to support the family of the person that has a substance use or alcohol issue, because they need as much assistance oftentimes as the person who is suffering from the addiction. The COPE hotline is also a nice option here in town. And I always use a mentor's phrase, which was, don't worry alone. If you truly are concerned about somebody and something is weighing on you, I always think it's in your best interest to benchmark it with somebody else, professional or otherwise. I also alluded to you, I note that some people on this line are leaders of industry and leaders of businesses. This is a free resource I always include. It says psychiatry. It's not just for psychiatrists. It's not just for mental health issues. It's really focused on personal well-being and burnout in the workplace. And it's a great website. Everything is free. There is no need to sign up. You are not tracked. This is not part of a research study. This is purely to provide free assistance to people that might need it. If you are worried about some of your colleagues or think that your team needs a bit of a jump start or some support, there's some great tests, screening tools, resources. It's a really nice link. Now, I was also asked to speak to my primary employer, which is Milwaukee County. And the county resources are, as I mentioned, fairly robust. When I do my work at the statewide level, which is kind of traveling around and trying to help other more under-resourced counties, they are always very much amazed of what we have. And I'm very pleased with that. I think that it's a very, kind of as Alex mentioned in our intro, a very, very dedicated, passionate group of individuals. And that really starts with our psychiatric emergency room, which is known as PCS. There are more and more psychiatric emergency rooms popping up every month, but ours remains probably one of the most long-standing and one of the largest functioning ones in the country. It is 24/7, it is fully staffed, and it is always accessible to the community. So very often people can come by when they're having what I note to be one of the worst days of their life. So when you're not sure what to do and going on a website doesn't make sense, and the idea of sitting on hold or waiting for somebody to pick up a phone doesn't feel very friendly, and you need that in person, that moment right now, this is always one of your best options. You can drive up like any emergency room, you can bring yourself, you can take a bus, you can ask somebody for a ride. We are always there. And I can say confidentially that 2 of the cases I handled on my overnight last night were people with really no prior symptoms, but had had enough issues in their personal life during the pandemic, they needed to talk last night. And if they had not, things could have become much more adverse. So I was glad that they were there. They had a good experience. And that's kind of what we're there for. I saw a chat pop up, so I'm trying to check on that real quick.
If you'd like, Tony, I can read that to you.
Please, that'd be great.
Yeah, great. From Steve Chevalier. Thanksgiving and Christmas holidays are looming and more than the normal stressors. Any stats on how this affects mental illness and any suggestions for coping in times of social isolation and pandemics?
Wow. Okay, there's 3 pieces there. The first one, the holidays. COVID or not, the holidays are always peak times for suicide, unfortunately. Mental health issues are not as increased as people think, but the really adverse outcomes are. I think that is often tied to increased substance use during the holidays. It's also a time where even if family members don't get along well and maybe shouldn't be spending time around each other, we tend to spend time around each other at the holidays. And so a lot of things kind of percolate. Kids tend to be off school, people are off work. It's also one of the highest times for layoffs in the most industries because it's coming up near the end of the fiscal standpoint. So I think at baseline, that is a high risk. During this pandemic, my main answer to you, sir, would be I don't know yet. I can see a pro and a con. For the very reasons I just mentioned, having a little bit more isolation and not being under the stress of holidays, I cannot tell you how many people I have talked to that have said to me off the record, I'm kind of looking forward to this holiday season. Not that I don't love my family, but it's always such a big deal and there's so much stress and there's so much of this. There's almost something relaxing knowing that we don't have to go through that this year. Now, I know there's people on the other side of the coin that live for those large gatherings and the community and the fellowship that it's going to make this more difficult. So I can't really, to your second point, I can't really predict how this is going to go other than to say what I just said. I bet you there'll be some people that'll be better off for it and some that'll be worse. And then the third part that you mentioned was really, I think, more of a global ask on social isolation. The isolation is not good. The only population that is somewhat, we have not seen a lot of change in their morbidity and mortality is the population of people dealing with schizophrenia, who often will joke with me, Doc, I've been socially isolating for years. That's kind of what my illness does. And so they've handled it better than other places have. But for other people, oftentimes what we are encouraging people is to interact with others, to grow with others, to care for others. Altruism and fellowship are very powerful coping techniques, and those are limited. Even with the technological options we have, it makes it very, very difficult. So I think the best thing you can do to answer your third question with social isolation is still find a way to interact as much as possible. There are several people that I work with that I've suggested they set up schedules for who they are going to Zoom, Teams, WebEx, whatever you're using, FaceTime, but make it a schedule. Start seeing people more and more often, because I think the more that you have that down, then you don't sort of fall off into that dissatisfaction or you lose synergy with your social kind of network. And it's a concerning point. It may be the most concerning point to me as a mental health professional is the social isolation.
Tony, I see your slide up there says the future, and there's one question here that might help us talk about the future and perhaps get you to finish your presentation, which is from Marianne Cantor. The 2019 gap analysis is interesting. Any thoughts on how you think those stats might change in 2020 and what the future holds? Yeah.
My guess is, because I think of this as a very large ship turning around in the middle of the ocean. It takes a while. I don't expect, if I've looked at all these gap analyses and they don't change dramatically from year to year. Most changes are in 5-year episodes, so to speak. So I would expect 2020 will be drastically different. The one thing that might change, and this is where we have to try to find some optimism and some growth, is the telemedicine has grown during the pandemic, particularly when it comes to outpatient appointments. And this isn't just mental health and psychiatry. This is nephrology, cardiology, family medicine. The no-show rate is very, very decreased. There are more people making appointments. Now, you could argue what is the quality of that appointment, and I would tolerate that argument with you, but more people are showing up more often now that it's virtual. And particularly for somebody like myself that works predominantly with underserved populations, that has been really shown. Because for a lot of our patients, the hardest issue with access is geographic location and transportation. And once we went to a telehealth for our outpatient to kind of immediately get in there, starting back in March, our no-show rate has been close to zero. Now, I can't say everybody's going to have those same results, but I think it is an example of if we can keep on seeing parity and compensation for telehealth, some of those gap analyses may change faster than you think.
Well, I was going to let you get back to your presentation, but there's a question here that ties right into that, which is from Brenda Campbell, who says, excellent presentation. Thank you. There seems to be more and more online therapy options, telehealth popping up. What do you think about that? I think you just said that. And any advice on how to determine competency and any concerns about confidentiality?
My confidentiality concerns, I'll answer that one. As long as it's a major platform, I'm not as concerned. And if you want to reach out to me offline, there are people that are better suited to answer that question that I can put you in direct contact with. I have colleagues in the city that have been doing nothing but telehealth for a decade, long before it was popular. They've researched every single thing. They know which ones are HIPAA compliant and which are not. I'm a little bit less concerned. I think if a platform is going to get hacked, it has just every much a risk to being hacked if it's in my hospital than if I'm using it to telehealth into your house. I'm not as worried about that. Now, competency is a bit of a different question, because now we are talking about what is the conversation like? And I can tell you just personally, I've had patients express it both ways. I've had some that have loved it and said, Doc, I feel more comfortable in my own, sitting in my robe and talking to you on my couch rather than coming into your office. So that's great. At the other point, though, sometimes people's houses are not the most relaxing places. And when you're talking about confidentiality, trying to keep family members out of a room when somebody else is having a conversation, or maybe you all share the same computer and somebody else wants to use the computer for something else, the competency issue and how good of an evaluation that is, if someone is having the worst day of their life and they're feeling that badly, I would still rather be sitting next to them 2 feet away. I think there's something that is garnered by the human contact and being close and nearby and privy to the symptoms that they're having that I think can't be replicated. So I'm not against it. I think this is wonderful, but I think there will always be a need for in-person services. Really, really good questions. And actually, yeah, go ahead.
Go ahead. I was saying it's about 12:45. Do you want to finish your presentation before we get back to it?
And I'll pop back to this. So these are all good. So yes, I was asked to kind of comment on where we're heading, which I think is a very fair question. We are one of the largest mental health providers, and so people have a right to have interest. I like to remind people, since people always ask me, they're like, hey, you work at the county, you know so-and-so, right? I'm like, the county is a very large group. Yes. Tens of thousands of employees that I do not know. So the county is the larger piece. We, as the Behavioral Health Division, function under the Department of Health and Human Services is the subsection. And BHD right now, which is out here on Watertown Plank, is currently going through what I call 3 big arms of change. One that you may have heard of is inpatient units. So people that are admitted to county psychiatric units. It's not a group that I oversee, but a group that I work with. That is being privatized. There's a group coming in called Universal Health Services. They've already broken ground and are building their facility in West Allis. So somewhere next year is what we have been told. They will begin taking the inpatients that formerly would have been admitted out here at Watertown Plank. Now, the county itself is still maintaining a robust crisis service, predominantly with our mobile outreach services, crisis response teams, crisis lines, warm lines. Some of you may have heard of our, what we call our CART teams, which is our teams where we pair a mental health professional with a law enforcement officer. That's all staying part of the county and being county run. Then the third component is another one that's under me, which we talked about, which is the psychiatric emergency room. Probably the most important piece, also the most costly piece. Anytime you're talking about 24/7 employment, 365 days a year of physicians and nurses. And for a county budget, that can be very complicated. That's why it typically fits under a health system budget. So thankfully, there's some good work undergoing as we speak to have a new psychiatric ER relocated in the city that would be mutually funded by the county and the major private health systems, which is a really nice idea. Not just because it's a service that our community greatly kind of responds to and values, but also because it more equitably distributes the financial obligations. The health systems benefit greatly from having this present, and I think they are now financially kind of getting into that as well, which will be good for everybody, including the county taxpayer. So before I take some more questions, I'll give a little bit of a wrap up. I know this feels a little bit like an after school special, but please let me say it once on the record for you guys. Take care of yourself. Anybody on this call is a leader in their own right. In whatever particular work in business or industry that you do, you are a leader in your own right. And it's incumbent upon us as leaders with people that do depend upon us and count on us to take care of ourselves. And sometimes that means having the confidence and the courage to raise your hand and say, I'm not doing well. Can somebody please help me? I've always been much more impressed by leadership that can acknowledge their weaknesses as well as their strengths, particularly since typically acknowledging the weakness becomes a strength in of itself. Acknowledge that we can't avoid the pandemic. It is here, it is present. From the very well-worded questions you guys have had, it's clear that you understand that, but we need to represent that to other people. I'm still in conversations where I hear a lot of denial and minimization of the pandemic. And to me, I kind of treat that like when I hear anything that is racist, sexist, or bigoted. If I choose not to say anything to it, then I am tacitly endorsing it. And I'm just not comfortable with that as a human being. And at least on the mental health provision of care, we have a unique perspective to work on this. And I think a lot of good things are happening. We just have to acknowledge the concerns. And the concerns are, like I had mentioned to you in the middle of the presentation, we're seeing more and more people need help when there's less and less services. And unfortunately, a lot of this is tending towards suicide. So before I take the questions, the last quote, and once again, replace physicians with whatever you choose to. I just picked this quote because I'm a physician. Physicians are the proverbial canary in the coal mine. While the canary may be sick, it is the mine that is toxic. Caring for the sick canary is compassionate, but likely futile until you get fresh air in the mine. And that's how I look at this. We are always focusing on individual people, as we should, to take care of everybody in an equitable fashion. But that being said, if we're talking about really changing our pandemic approach, or really changing our approach to suicide during a pandemic, that is going to require systems-based change, not just individual-based change. So with that, I think I can get the chat box open. There it is. I'll look through these and see what we can get to.
Why don't I read them for you if that's okay? Just
go right ahead.
Okay. So from John Frankie, do we have any data with respect to increased time of people being online, not for work, but for shopping, communicating with friends, or reading mainstream news, or just surfing social media, blogs, maybe the dark web? Yeah.
So John, do we have data? Yes. As a scientist, do I consider it quality objective data? Not really. I think it's one of those things that it's clearly with more time on devices. Internet plans are up, technology and devices are up. We can assume there's a lot more social media traffic, and the social media companies will share that with us. But I don't think the data is really tying into things per se. The only decent data I've seen that is causative, not simply a correlation, but actually has shown cause, there is decent data in adolescence. There's been a lot of focus on the percentage of time spent on social media, and the risk of developing particularly depressive illnesses is quite high. Now, if you really want to unpack that, there's a lot of different things there. It probably depends what they're looking at on social media. I would argue adolescents of today's day and age are facing a challenge that none of us can comprehend, which is the idea of online bullying. Things are markedly different in today's society as far as being bullied and tormented than something I would have dealt with 30 years ago. And so I think that has to be tied into the rise in suicide in that group, because how people are shamed during a very, very vulnerable time in your life is so much more public, perpetual, and documented than it ever has been before. So I'm sure it's there, but I wouldn't feel comfortable sending you to a research article and say, you should check this one out, because I'm not so sure it followed the scientific method that tightly.
One of our participants here asked how he might access this program to share with others, and our programs are all on our website. And if you have any trouble accessing them, you can check with Michelle and she can send you a link that you can share with others as well.
And if I can build off that just for 1 second, and if any of you, if this topic creates more interest, or you think of a smaller group that might benefit from it, or you just want to chat it out, reach out to me. I'm happy to talk with you offline.
Terrific, thank you. Karen Hung says, in general, for the broader population, what are important mental health exercises or disciplines for us to maintain positive mental health and behavior health? Practical things we can do with some frequency that would be nurturing.
Thank you, Karen, for getting down to the nuts and bolts. I appreciate it. You've heard it from other people, but if it helps to hear it from kind of a mental health professional, I think the best thing we can do in this era is to continue to do the things that we love as best as we can. We all have things that lift us up. It depends. I mean, for some people, it may be watching TV, reading books, prayer, socialization, playing with grandkids, exercise, whatever your thing is, the key is to keep doing it. And I've noticed that work with people. I mean, if you've noticed some of the things purchased during the pandemic, exercise equipment is one of the highest things up there. Online yoga classes are selling out. Now, could that be people's fear over body image? Yeah, but I think on a deeper level, this is people recognizing I have to stay active. And if I can be fully transparent with you, Karen, I am very guilty of, I tend to get caught in a web of, I love to read, and I will get caught up in all the reading online. And next thing you know, it's been 2 hours. I'm like, this is not right for my well-being. Hit the treadmill, grab my kids, go outside, play catch, do something to disconnect from this. This is going to be a marathon, not a sprint. I would argue we're already in the marathon. And so nothing that you do on a Tuesday is likely going to affect Wednesday. Keep on sticking to your schedule. I think that's the key. Because if you remember my comparing it to a grieving process, one of the ways that people get through grief is by sticking to a schedule, because grief throws us off our schedule. It takes what we're used to and makes everything discombobulated. So the more you can kind of schedule yourself down, keep on doing the things that you like. And me personally, I'm a big fan of anything where you can be altruistic. Altruism is one of the greatest mood elevators that are known to people. Doing anything we can to help people. I love seeing that you guys were working with the food bank and other things along that line. That can make all the difference in the world.
So President Darren asks, Tony, what will keep you awake in the next 6 months as the pandemic escalates, the vaccine remains a time off, and public schools look for ways to cope with a shortage of professionals to assist? What's going to keep you up, huh?
Well, you had me at schools.
No.
That's probably my largest concern. And I can't completely disassociate that from my role as a parent of 2 young kids who are currently still in school, as scary as that may be. But I think even as a mental health professional, how our kids, we just mentioned, this is the most vulnerable group, right? It's the group that we're seeing the highest range of issues in, and they're losing that schedule. They're losing a lot of that. And I come from a family of nothing but teachers. So I fully recognize, I'm impressed by what the education departments are trying to do. This is an incredibly big lift, and I think they're doing it with grace and process. The hard part is it's still affecting kids. So my thoughts, Darren, would be I'm a little bit nervous about the studies that are going to come out in 2025 and 2026, looking at the kids and how our educational performance may have fallen off. And not just education performance, but socialization. Are we getting into a different socialization? As much as social media and this type of Zoom connection is nice, I still think there's something about kids being around kids. With adults, it's a bit different. I don't think you'll see as much of a drop in high school and college. One could argue high school is approaching more of a collegiate educational realm, which does involve a lot of self-study and home study. But when you're talking about primary and secondary education, I get a little bit nervous about grades K through 6. That's what keeps me up.
Okay. Well, I think we're just about out of time, and I'm going to just close with a comment from Karen again, or I guess it's from Steve, who was talking about the need to maintain some continuity, and we've been trying to keep that rhythm of Rotary going throughout the pandemic. And so, good plug for Rotary. Thank you, Tony. And with that, I'm going to turn it back to Darren to thank you and close us out here.
Great. Thanks. Thanks, Mary. And thanks, Tony, for being here today. Great program and absolutely timely. In honor of community leaders like you who speak to our club members, we will be making a donation to the YWCA Southeast Wisconsin, whose mission is eliminating racism, empowering women, and promoting peace, justice, freedom, and dignity for all.
Thank you very much.
Absolutely. Absolutely. Next week, we are planning another timely program led by fellow Rotarian John Franke. John will explain what the heck is going on with the election recounts and certifications and what it all might mean for the long term. So please join us for that. Thank you all for being here today. Have a healthy, happy Thanksgiving, and this meeting